Hello and welcome to this episode of Sharp Scratch. This is a podcast brought to you by the BMJ, where medical students, resident doctors and expert guests come together and discuss all the things you need to know to be a good doctor, but that you might not get taught at medical school. My name's George, and I will soon be starting my final year at Warwick Medical School. However, this year I've been working at the BMJ as the editorial scholar, looking after all the content that BMJ student has been producing. Today we're joined by two panellists, someone that you'll have heard before if you're a long-time Sharp Scratch listener, and somebody new. We have Éabha and Mary. Would you both like to introduce yourselves?
Yeah, hi George, it's great to be back. My name is Éabha and I'm currently in my fourth year at Lancaster Medical School in the Northwest. I've just finished my palliative care placement and I'm now finishing off the year in general medicine.
Yeah, and hi George, my name's Mary. I'm a final year medical student as well. I'm just on my assistantship block now, so I've got about 6 weeks left until I qualify, which is really exciting.
Amazing, thank you so much. And I'd also like to welcome another Mary. We have Dr. Mary Miller. Dr. Miller, could you tell us a bit about yourself, please?
Lovely. Thank you, George. Thank you for the invitation. So I'm Mary Miller. I'm a consultant in palliative medicine based in Oxford. I have some other parts to my job, but the main part of my working life has been working in palliative medicine. I did 4 years medicine and then swapped across in theory to do a quick stint in palliative medicine and forgot to leave.
Wow, that's amazing. I can't wait to ask you more about that. I'm so excited to have all three of you with us today for this episode. There's a topic that has come up a number of times over the years in Sharp Scratch, and quite, I guess, morbidly, that topic is death. But I think it's really interesting that this is a topic that has come up amongst, Éabha will definitely know this, quite a few of the editorial scholars' episodes, whether it's conversations about being present at the first death that you've witnessed, or certifying a death, or even coping with feelings of grief and sadness. We know that as a doctor, we're in a career where conversations about death and dying are inevitable. So in this episode, we're going to speak a little bit about a career in palliative medicine, end-of-life placements, and some of the feelings that this might kind of stir up for medical students. So my first question really is for you, Dr. Miller, and it's what drew you to a career in palliative medicine?
Well, I was firmly set on doing care of the elderly medicine after having qualified, done internal medicine for, it was way back when in the distant times, but I did 2 years on medical rotations. And then in those days, you moved on to being a registrar. And I was a registrar in care of the elderly medicine. I decided on that as my career. And as luck would have it, one of my friends was going to a lecture in the evening about palliative care. And I was at a loose end and I just joined in. And I sat in the lecture theatre listening to the person who was then the only consultant in palliative medicine in Ireland. I'm Irish and I trained in Ireland and worked for the first 4 years in Ireland. And as I listened to him speak, I thought about all the patients that I had stored up in my first 4 years post-qualification, whom I felt sad that I hadn't been able to look after in a better fashion than I had managed, guilty that actually I hadn't been able to provide them with a better quality of life before their death. And I sat there and thought, I know, I'll ring him up and I'll say, have you got a job? And can I come and spend 2 or 3 months there and learn everything there is to know about palliative medicine? And then I'll go back to my career in care of the elderly medicine. And I phoned him, being young and assuming that I could just walk into a job there. And he told me that the job he had won was hotly contested and I could apply like everybody else. So did. And from the moment I walked into the hospice, I was fascinated by palliative medicine. And that led me to forgetting to leave.
It's really fascinating that I think palliative medicine is one of those things that I don't hear that many students while at medical school saying, this is definitely what my plan is to go into. I don't know if that's also your experience, Dr. Miller, that maybe people come to it slightly later in their medical journeys.
I wonder if it depends on your life experience and also the patients you have happened across. So when I was a medical student, you'll gather that there was absolutely no palliative care, palliative medicine. I didn't know anything about it until I came across Dr. Michael Corney and went to work in the hospice in Dublin. I see lots of people, in fact, one of whom has just been appointed to the training program in Oxford, who was interested in it, did it as a work placement, and it was an experience in their life that led them to think about this branch of care. And perhaps the difference between the before and after experience of a relative that they had seen struggling, introduction of palliative care, and thankfully a better experience. So I think as palliative care has become part of the undergraduate curriculum, it'll resonate because of people's life experiences and because of where people are at in their thinking about medicine, and also perhaps as you begin your clinical attachments, people you see on the wards. So I wonder, is it luck that some people happen across it?
That's really interesting. And I think I'm going to put that question out to Éabha and Mary, because we're all we've all been through medical school recently or still at medical school. So what has your kind of exposure to palliative medicine been like?
What you said, Dr. Miller, really resonates with me. I love care of the elderly. It's probably been my favourite rotation that I've ever done. And went into my palliative placement thinking I'd enjoy it because I like care of the elderly, but not thinking I wanted to do it beyond that placement. And I left the placement seriously considering a career in it, or a career maybe not as a consultant in it, as a specialist in it, but certainly as a career influenced by it and the philosophy of hospice care. It's quite inspiring to hear your story. My whole kind of philosophy of medicine, and I think it's quite similar to other people end up involved in BMJ student based on conversations I've had with George and others, is I really went into medicine for the humanity of it, and I stay in medicine for the humanity of it and the whole person kind of care, and in palliative medicine as well, the whole family. And I think when you get to see that done well, from the kind of very beginning of my career, I'm seeing that like as something that I want to take forward throughout my career. I don't know if that's something that you relate to, Mary.
Yeah, I think I resonate a lot with what you've said about wanting to stay in medicine for the humanity and stuff like that. Yeah, that definitely is something that I feel too. And I think I've been really fortunate actually that I've had a fair amount of exposure both before medical school when I worked in oncology for a bit. So I saw some really excellent palliative care there. And then I also had really positive experiences on placement in palliative care through medical school. So we got to go to a hospice and we had quite a lot of time actually spent in palliative care. And that really shaped, I think, my impression of it and the way that I think it works and how important it is. So yeah, I think I'm fortunate that I've had the exposure. I know that other people don't necessarily always get that much exposure that early on in their career. I don't know if you agree with that, Dr. Miller.
Yes, I think so. While it's part of the undergraduate curriculums across the whole country now, there are varying amounts of time that are devoted in different curricula to it.
And honestly, something I found in Lancaster is, and I don't know if this is something, in fact, I'd be quite interested to hear, though I don't know if this is the right episode, George, to ask. But like we go to placements in various hospices because hospices are quite small. I was just wondering if you notice a difference in your experience of one hospice versus another. Because I guess it's something that scares me about palliative care, in the same way it scares me about being a GP, is how variable the experience is depending on the team that you're working with and whether that kind of translates into your work in hospices.
I may be the wrong person to ask because I have spent the vast majority of my time in the UK in Oxford, both as what was a specialist registrar back then, but which would now be a specialty registrar, and then working as a consultant here since 1998. But I have worked in several different units before I came to work in Oxford. And I think you're absolutely right, Éabha. You will have different experiences in different places. I think there's two things that I would bring to the conversation. The first is I have learnt as much from those of my seniors whom I was determined not to turn out like, as I have from those I admired and loved. So I think that it helps define the type of doctor that I thought I wanted to become by having good experiences and bad experiences. The other thing is what you like. So I am, if you cut me open, would say hospital doctor at my core. I love hospitals. I always have. So I think that for me, I know that I have favourite areas in palliative medicine, but I value the breadth of it hugely. I am at my happiest when in Oxford the consultants rotate every couple of years. I'm at my happiest when I'm in the hospital. I love the hospice, and I'm perhaps managing my community placements. Others would have different emphasis, and I think what palliative medicine brings me is the ability to be able to work across the piece. And that's what our patients experience, isn't it? In that they don't really particularly care whether they're in a hospital or a hospice, but they need the care at the end of life to be really good. So I think there's two things. I think you're right. It is important to choose your team really wisely. It was easier in my day when you were able to go and look at units and think, I want to train there and there, but not there. That's harder now, but that you will learn wherever you are. And secondly, then thinking about who are you as you are becoming, which continues throughout your whole career, doesn't it? But as you're becoming a doctor, what suits you? Where are you meeting that balance between satisfaction and being able to deploy your skills?
So one of the emotions that this kind of stirred up for me when I was planning this episode, Dr. Miller, was times when, as a medical student, I felt a little bit uncomfortable and determining whether that's because the discomfort is coming from me or if it's the situation. And one of this is like facilitating conversations that might feel a bit awkward. And sometimes those conversations, particularly, have been around breaking bad news to patients or conversations around kind of end of life care when I'm kind of feeling like, oh, am I being a bit voyeuristic by being here? Should I be here? Am I actually benefiting the patient? Like, is my presence in this situation, a good thing for patients? So I wanted to ask a little bit about, do you think this discomfort to some level is a normal experience of being a medic? I'm asking for reassurance. Does this feel better with time? Do I get better at this over time? And kind of how to cope with those feelings that maybe conversations around death and dying might stir up for some people.
Absolutely, George. So without doubt, you become more comfortable with time. You learn language and you learn communication skills, other nonverbal communication skills that facilitate you doing this really well. I think that it doesn't suit everybody. So there will be, as you leave medical school and you start your foundation and IMT jobs, it will be time to discover whether this is something that is for you or is not for you. So medicine's wonderful, isn't it? And there's this little narrow box you can answer, and then the world opens up from journalism to law to end of life care. So I think then pulling back to thinking about how you feel in a situation. I think that as a doctor, I have learnt to listen to how I feel in consultations. That the ones where I'm starting to feel edgy and uncomfortable and annoyed, angry with the patient, are is transference that I need to be aware of and listen to, because if I'm feeling like that, it's maybe me, maybe a bad day, but it's often I'm picking up unspoken stuff from the patient. So for me, I think what I've learned to do over the years is listen to that really well, and in the consultation, give myself a few milliseconds to think what's going on here, and perhaps change tack with the patient and ask them how they're feeling, or is there any anger there, etc. But leaving that to one side and coming back to your really interesting question about feeling like sometimes you are voyeuristic was the word you used, but that you are there in the conversation when you may not have a right to be. I remembered a biography I read that was written by Balfour Mount, who was one of the Canadian giants, and he went to St. Christopher's Hospice back in the 1970s. And the team there did not allow him to be part of those conversations with patients. And I remember reading that biography maybe 3 or 4 years ago, and thinking how very odd, because I've got completely used to having clinical nurse specialists, medical students, nursing students, whomever, sitting in on the consultation and thinking about, why do I believe that is correct? To actually ask our patients to share those incredible moments in their lives with us. And I think it's correct because at the start of my career, I did not know how to do these things. And I learned when I worked in the hospice in Dublin with Michael Carney. He was the best communicator I've ever worked with. And I learned from him by watching him do it. And I was one of the team, so I didn't feel quite on the periphery as you might as a medical student. But patients gifting us that as doctors, learning how to develop our craft. The gift they give us means that I will do it better for the patients who I'm looking after in the future. So I would come back, George, to saying sit with the discomfort because it is the best way of learning. And that when I'm sitting in that conversation with the patient, knowing I have to have a very difficult conversation with them that they may or may not be quite ready to hear. I think that as a doctor, I can set the clinical space so I am commanding the patient's attention and focusing on them and listening to them, and that both the patient and I lose who's in the periphery. I sometimes get a shock when somebody talks in that kind of a situation because your focus is on the patient. And I wondered, as that brilliant question you asked, George, I wondered if there's also an opportunity as a medical student to actually go back to that patient to make sure that whichever doctor is having that conversation has asked their permission for you to be there. And I think I'd elbow my way in and double check that that's actually been in place. And secondly, to go back to the patient and even say thank you, bring them a cup of tea, just check how they were. And what I hear the patients saying is that they worry about the medical students and the younger doctors, the resident doctors who are around their bedside. Because sometimes they worry because you remind them of their grandchildren, sometimes of their children, but they're looking after you and wanting to protect you. So I think there are many things in play at that consultation, but I think it's a gift that patients very generously give to us, that we should avail of it because it will help us learn how to do it when we're in charge of those conversations. And there are ways of thanking people.
I find that quite reassuring to hear. Also, what you said about patience, I hadn't ever even considered that really at all. But I quite like knowing that. I think that there's like a bit of that on both sides, worrying about each other.
Isn't that the best of humanity, really? Yeah. Yeah.
Isn't that just what life is? Like, all we do is worry about each other over and over again, forever. And like, that comment has actually taken me back a little bit because the times that I've got the most upset on placement have been because so and so reminds me of my parent, grandparent, auntie, uncle, do you know? So I would hate to think that I'm making people feel the reverse, but same of that. But I agree, George, it's very reassuring. But I guess I would also just say for the listeners at home, like, it is heavy to be like, like I came straight from school to university. It's heavy to be in your late teens, early 20s and be sitting in conversations like that, especially if you've never had them as part of your personal life. And then your entire kind of first insight into the end of life and bad news is through that professional setting. That's a big weight to carry, and if you are feeling that weight, I would go easy on yourself, or like try to not be so hard on yourself. I wish I had had kind of this sort of conversation when I was at the start of medical school, because it's something that I have struggled with and then continued to struggle with, kind of bouncing that ball between my personal grief, if you will, and my professional life. So yeah, thank you very much, Dr. Miller. Again, I'm just really I am genuinely really appreciating all of this insight. It's a rare kind. It's a blessing. It really is.
Yeah, and I agree as well. I think the point you made about going back to the patient afterwards, and potentially speaking to them or taking a cup of tea or something like that is just, we're talking about showing the humanity, right? And I think that's a really nice way to do that, and not really something I'd thought of before. But yeah, that's a really nice point. So it's definitely something that I think I'm going to try and put into my practice now going forward. But one thing I would say is I think when it's come to seeing bad news being broken on placement, the times when I think I've felt like the environment has been maybe a bit more controlled, or maybe there's been slightly more time there and more space for me to be able to speak to doctors about it afterwards, or maybe have a conversation with the patient, has been in clinic rather than on the ward. Because obviously sometimes on the ward there is time, but often there's not loads and loads of time. So that's maybe something that I think if you do get the opportunity to go and see the bad news being broken in clinic, that can be maybe a slightly easier scenario to go into, just because it's normally more prepared. The patient might already have a bit more of an idea about why they're there. And that's just been my own opinion, but I don't know if you'd agree with that.
Absolutely. I think that there is more privacy. Our hospitals are hard places to be in as a patient and to work in to deliver this. And, there's fewer and fewer spaces in the hospitals where you can have private conversations. And I think you're absolutely right, Mary. If this feels close to the bone for you, I think trying to do your learning in better places rather than trickier places is a good start. Something, Eva, as you were talking, triggered in my mind about that we are human beings, as well as doctors. And when my dad died, I thought, which was just before COVID, I had thought that I knew the things walking back into a palliative medicine job. I knew the things that would trigger grief for me, and I was wrong. I got blindsided once or twice when I was on the ward at the weekend looking after people. And it was small things rather than the big things that my dad would have done that were the things I was not prepared for. And I think working in palliative medicine, you do develop coping strategies, and you do allow yourself to go, today, I just try not to harm anybody and I do the best I can. I'm not going to be at 100% today, and that's just how it is. It's the same for the rest of medicine, isn't it? But I was just thinking, as a medical student or a resident doctor, walking into those situations, there will be times in your life when you have no defense between you and the emotion. You can always make up an excuse to get yourself out of that situation. And if it's predictable, you can talk to the senior that you're going in to the consultation with. If it's unpredictable, you can always say, excuse me, I just got a phone call, whether you did or you didn't, and exit stage left. And I think the other thing that I wanted to add in is that everything that's out there in the literature from patients and their families is they do not mind staff being upset or tears rolling down our face. They do mind if it's about us, not about them, because they're the sick people, but they don't mind if they get upset. In fact, usually what's out there in the qualitative literature is actually they recognize that staff are affected, and that it's somehow reassuring that their tragedy is something that makes us feel sad too. So I wouldn't be trying to fake emotion in any sense, but I would also just cut yourself some slack. If you're tired and actually it makes you feel very sad and that shows in your face, that's okay.
That's so reassuring to hear. As someone who has found that the thing that makes me upset sometimes on placement is not the thing that I anticipated would make me upset. Like, I've spoken about this on the podcast before, but my mum was diagnosed with bowel cancer, and I went and watched the surgery that she had a couple of months after she had it with a colorectal surgeon, and watched that absolutely fine. But then the thing that made me upset on placement was something completely left field that I didn't anticipate stirring up those, making me have that kind of a reaction. And I think just acknowledging that at the end of the day, we're not robots, and there might be times when we get upset, and that's fine. And patients aren't going to hopefully think any worse of us because we have human emotions. I feel like this conversation on this episode today is just like having a cup of tea. Like, I feel like really reassured by the conversation. And that's what I think I want people listening to also feel, that actually you're not alone in having some of those feelings. But maybe we just don't talk about it enough. Maybe we don't sit down and say, oh, actually, I cried after placement today, and that's okay.
Yeah, perhaps we don't. And we're taught in medicine to be tough, aren't we? In terms of just keep going, there's a shed load, and whatever we're going through, the patients have got a worse time. And I think that's true sometimes. It's not always true, but actually having friends around you. I was really lucky that the university I trained in, about 50% of us stayed on and worked in the same hospital for, 2 to 4 years. We knew each other really well. We'd seen each other through exams and a whole load of neuroses. So we knew each other well. And actually, you could always find somebody in the hospital you could go talk to.
I was going to ask both of you, actually, panel members, has there been a time on placement where you have felt an emotion that you didn't expect? And kind of how have you coped with it in the moment? Or have you ever felt uncomfortable and been able to say, actually, I'm going to step away right now? Because sometimes I think those conversations with seniors in particular can feel a bit uncomfortable.
I literally started off this podcast by talking about how much I loved care of the elderly, right? But my story, which I've probably said on Sharp Scratch before, is from my care of the elderly placement. And it was just that I was reminded of my own family, and I was reminded of the age of family members when I received comparable news to them. And I saw so much of myself in this family. And in the moment, I was completely fine, and I went about my day, and I did the professional kind of good medical student thing. And I don't think my seniors knew half of it. But I came home, and my partner, who lives in Scotland, was visiting for the weekend, and I just sat on my sofa and cried for like 4 hours because the full weight of my own family situation just hit, and I just took that day on placement especially badly. I totally separated my kind of experience of that day on placement from my seniors on that placement because I didn't want them to think any less of me, and I sort of didn't want to bring my family situation and my own kind of personal difficulties onto that placement because I had such a positive experience of it, and I didn't want the seniors there to kind of think, not think less of me, but just I didn't want to kind of disrupt that kind of image of the placement I had painted for myself with what was going on at home. So yeah, I've definitely had moments like that on placement, and my answer to everything is usually cry. After crying for 4 hours, I felt much better. Like I really did, but I also it is all the social support. Like I needed to have my boyfriend there that night. If I didn't have him, I'd have needed to have a friend. I couldn't have got through that evening by myself. It probably would have been a lot worse. And I was lucky to be well enough supported kind of in my personal life. And I do recognize that there have been similar times where I haven't had that same level of support in my personal life, and I've taken situations on placement to be a lot harder. So yeah, again, as George said earlier, just this whole conversation is like a nice cup of tea. Like I think I've received a lot of insight and reassurance that I think I've needed to hear from like someone so kind of specialized and senior for quite a long time, and I genuinely can't thank you enough.
Yeah, I guess my dad's also been unwell fairly recently, actually, towards the beginning of my medical school career. And I think going on to placement, I did end up also kind of similar story to George. I ended up watching the operation that he had and then kind of following up the patient who was ill in the same way that my dad was. And I think I found the process of doing that quite challenging emotionally, just because obviously it reminded me of a lot of the stuff that was going on for me at home. But then it was in a way quite nice because I then got to see the patient the whole way through the process. And when my dad was unwell, it was actually kind of the pandemic, so I didn't really get to see very much of him. So I saw the patient through that process, and then at the end, I have a really supportive clinical partner as well who I do placement with, and we ended up actually getting the patient like a get well soon card kind of thing, and I ended up going and seeing them on the ward, and that was actually a really nice moment because it kind of felt like, if I know there were medical students involved in my dad's care, and I think if any of them, maybe they did do things like that for him and I didn't hear about them, or I'm not sure, but I thought actually I would have loved it if someone had done that for my dad. So in a way, it gave me the opportunity to try and treat that person the way that I would hope someone would have treated my dad in that situation. So I think it can be really difficult to see things that obviously remind you of home or remind you of family or friends. But I think finding ways to deal with those, whether it's kind of having to take yourself away afterwards and think about it and process it, or whether actually in the moment there's little things you can do, like provide that little bit extra support, or even just relating on a human level to what they're going through. And I found that really helped me.
Thank you. Thank you. I wanted to come back and say, wow, that's such an amazing story. But that what you both described is just life will reach into our medical careers and be there for us to cope with, while also needing to provide medical services. Um, I'm not naive, and I realize that everybody you're working with may not be in a position to be supportive. But what I've also learned over the years is that as a senior doctor, I've often worried about people I'm working with and think there's something up and I can't put my finger on it. And I think if you're in a place where those feelings are not going away, if you think that your senior doc is somewhat supportive, it is better to say that this is a difficult time for me. The Be Kind movement that is really interesting, I think, shows that patients are safer if we're actually kind to each other and we look after each other. So you won't be able to tell every boss on the firm, will you? But I think for some, if you're having a hard time, I think it's best people know. It's not to say that your medicine is going to take a dip, but that just perhaps people look out for you just a tiny bit more. It's a hard job.
Yeah, and I think because in that moment I was able to speak to the consultant because they were really kind, and the surgeon, and have conversations with them about what had been going on in my personal life as well. And then the way that they handled that was pretty amazing. That they would kind of come to me and say, "Okay, now I'm going to talk about the complications of this. Are you happy for me? Like, are you happy for that?" And they were really supportive, and also coming checking up on me as well, which obviously is a really positive experience. So again, you said earlier you can either learn how you want to be or how you don't want to be, and that was definitely a good lesson in the way to handle that kind of thing.
Absolutely. I just also want to say, like, I would definitely encourage talking to a senior about it if you're. I know that it's not what I did, but I think my learning from that whole experience was that a problem shared is a problem halved. And there is always someone, be that if you're a medical student at your medical school, if you don't want to go to one of the clinical team or one of the seniors that you're working with. Like my medicine placement, I'm only on one ward a week and then I change after a week, so I don't get to know anyone too well. So if you're in a situation like that where you don't kind of have a consistent supervisor for over a long period of time, talk to someone from your med school. If you do have someone who you trust, who you work with a lot, talk to them. Like it is just what you both described. Like it's just easier if you're not feeling so alone in what you're going through.
And I think for me, it gets slightly easier as I've gone through my kind of time at medical school to have those conversations. I don't know if I just feel more confident, but when I went to see the surgery that my mum had literally had, a few weeks before, I just announced basically when I got there, I'm not scrubbing in because my mum had this surgery, a few weeks ago. I don't know if I'm going to hack staying in for 10 minutes or 3 hours, but I'm just saying that I want to be here because I actually want to see this, and that's why I'm here, and it's part of my placement and I want to come to it, but I don't know how it's going to make me feel. And everybody in that room was like, okay, like there was just a really neutral reaction. And I think that was the reaction that I needed, and I found that really supportive. So I'm really glad that I did say that in that situation. And ultimately I stayed in much longer than I thought I would, and I'm not a budding surgeon. I've got to say I'm really really not a budding surgeon, so I can't say that I enjoy surgery, but I did stay in and I thought it was really interesting, and it was good that I felt like I'd prefaced it by saying I might not stay, and everyone was like, that's really fair, that's fine. So I do think sometimes when you actually have those conversations, they go better than you kind of anticipate. But Dr. Miller, I was going to ask, I think when it comes to kind of end of life care, I think sometimes the discomfort with conversations is that maybe there's a little bit of a like taboo about talking about death anyway. And I don't know whether different medical schools maybe approach that in different ways, but one of the things that my medical school said was like when having conversations with patients about kind of death and dying is like avoiding these kind of euphemistic terms. And I think maybe it's difficult to do that at first because we're not as humans like programmed to have these difficult conversations with people. And that's something that you have to learn to do. And it almost feels like a bit of a weird thing to learn to get good at, talking to people about things that we just don't really talk about as a society that often. But what do you think medical students can do to feel more comfortable having these conversations that they might not feel like they've kind of been brought up having, if that makes sense?
Yeah, thank you. That's a great question, George. There have been times through the ages when people have talked about this more and times when they've talked about it less. But coming to the current day in which we live, I think that there is discomfort and there is an avoidance of saying death and dying. And I would agree with the people who've told you about euphemisms. And I think that's because you have exhausted families who are listening to you talk. And it's so easy to miscommunicate. So I think being absolutely clear, deliver it kindly is the way to go. So I'd fully stand with what you've been told. In terms of practicing those conversations, I think firstly, recognizing that all of us, when we pick up a new set of skills we need to learn, we're not confident. So for instance, when I was training way back, the default in hospices was that everybody was for do not attempt cardiopulmonary resuscitation. Wasn't written down, wasn't discussed. You never did it. When I needed to pick up those conversations when the times moved to the current stage, and I needed to learn to have conversations with patients about DNA CPR in the hospice, it was a brand new set of skills. And what I did is what I usually do, which is I took myself off and did a day's training where you had to do some role play about the conversations and then came back and then learned what worked for me and what worked so that I didn't open up hope and possibilities for patients that were not on offer. So rolling myself on to thinking about how you could practice. This podcast is a great way to start. Actually, I think having conversations in our medical social circles about, how do I open my mouth and how do I start that conversation? And I think practice on your families. If, you're at a point in your family life where it is not unkind to do so. But I know that we regularly have conversations, I do work in palliative medicine, around our dinner table about what we would want when we're dying. So I know what various members of the family would want. So my younger daughter tells me, Mum, you decide. My elder daughter tells me, preserve life at all costs, even if that means ICU stay. And my husband would say, no preserving life if it feels futile. So having those conversations and finding safe places to practice, be that your family or not, I think is a good way to learn the vocabulary. I think the other thing is to understand perhaps why we feel this, because this is such a profound time, illness and dying in the life of a family. It's a profound time. We're walking in there. We want to get it right. So actually, in the same way as presenting or doing a podcast, a little bit of adrenaline goes a long way to improving your performance. A little bit of fear helps you focus on the conversation into which you're walking.
I think I have one follow-up question, and it's for anybody who's listening to this who might be feeling anxious about, because for me, I have to say I really enjoyed, we call it our kind of end of life, and it comes under our medical block, and we have like a week or like a few days, and I really enjoyed it. I found the teaching really good. But if anybody listening hasn't yet done a rotation, or perhaps even if they're an F1 who might have palliative medicine as a rotation in their jobs, what's the one piece of advice that you wished you would have heard kind of before your career that you would impart on them before, they go on to do their placement or rotation in palliative medicine?
Find opportunities to watch people to do it before it, if you can, before it is your responsibility. You'll gather from that, I like to do things well if I'm doing them at all. But if you have the opportunity, if one of the hospital palliative care nurses or doctors are on your ward, seeing one of your patients as an F1, if you can at all, go with them. You needn't stay for the whole consultation. Watch people do it well and ask your colleagues who does it well and watch them do it. If you're on your palliative care placements as a medical student, take full advantage of your clinical time, again, to watch those conversations. And although the staff might try to protect you and select the patients you're seeing, I bet conversations will open that they hadn't planned. So availing of those opportunities, I think. So that's one thing I'd say to you. And I think the second is, do not worry excessively about the words you choose. People will, we all know this, they'll remember how you made them feel. rather than the exact words you said. So I think that if you approach it with an intent of kindness, even if you think, crikey, I've fluffed those words, it'll come across well. So I think they would be the two things that I would have wanted to know.
That's amazing. Thank you so much for that. I'm going to hand over to the panel to see if you've got any comments that you want to add.
Other than just thank you, I sound insincere because I've said it so much, but like, I really do appreciate all of your words. Like, I've really benefited from being a part of this conversation. So thank you.
Yeah, I feel the same. I think just knowing that actually it's okay to be human and it's okay to show your emotions and have emotions around this, because it is really difficult to talk about, has felt really important. So yeah, thank you so much for your time. I just really appreciate it.
We'll be returning in a couple of weeks' time to listen to another episode with Dr. Miller and Mary and Éabha, our panellists today, where the three of us will ask you some questions that we haven't managed to cover in this episode about kind of our experiences around palliative medicine placements, as well as questions that have been sent in from other students. However, today that's all we have time for. So thank you so much to our panellists for joining us and everyone at home for listening. Thank you, Dr. Miller, for joining us as well. If you like our show, I'd love it if you could support us by leaving a review wherever you get your podcasts or sharing it with the people you know. Please keep in touch. We love to hear your thoughts on the show and anything you find interesting at medical school at the moment. You can find us on social media. We're BMJ Student on Twitter and Instagram. Sharp Scratch is also now on TikTok. You can find us Sharp Scratch Pod and keep up to date with all of our latest clips. If you'd like to hear other episodes, subscribe to Sharp Scratch wherever you get your podcasts, and in 2 weeks' time, you'll be notified of our next episode. Until then, it's goodbye from us.